I remember when I first came into working in palliative care and death and dying, I kind of just felt comfortable in the space and didn't really think a lot about it. You know, this is going back 30 odd years ago now. But as time has gone on, I've come to recognise that maybe the things that I didn't see or feel when I was younger are actually the things that are driving a lot of my sense of values. It's quite interesting. I really do think I was somebody that didn't feel my voice was ever being heard, and I think I've come to recognise that I really want to help patients and families feel like their voice is being heard, or junior staff or other people in the healthcare system. So in that way, you're advocating or creating an environment where people can have an opportunity to express who they are. And that means creating a safe space. Now, of course, we can't be out there sort of creating niches everywhere that people feel safe, but we can, through our practice, demonstrate that you can feel safe. And there's nothing more empowering when a patient or a family member says they feel safe, and they will use that word. So I think for me, it is actually me wanting to create safety, so maybe that's my own internal need to feel safe, but also it's my need for people to feel like they've been heard and understood. So people can tell their stories, but there's nothing more distressing when the person listening to the story is checking their phone. So you need to genuinely be connected. And that's, again, a very powerful tool. You can use all the medicines you like, but if people think you're being present to them, it's a very powerful way to be. And I think that keeps driving me to try and work with the patients that I see, but also help mentor the younger doctors, for the nurses to see, for the nurses to understand. It isn't just about the doing and the asking, it's actually creating this sort of safe space in that way. I think having somebody close to you die is very powerful. I think for me, even though I've had other people die in the years since I began working in palliative care, it was when my partner died. My partner of 20 years died. And even though I was able to understand and step back from the things that were evolving and things that were changing, I think it was obviously a very powerful experience, and an experience that I could reflect on and think, yeah, I am somebody who's got some sort of emotional ability to understand the situation, step back from being a doctor and being a partner, being a carer. And the power of that experience, it reaffirmed that maybe there was a sense of psychological well-being working with dying people, and the things that I was trying to see for our patients was really what I wanted to step back and see for my partner when it became inevitable that he was dying. The powerful messages for me is that if you can allow a person to be themselves, and you can manage the issues and problems that are surrounding them and allow them to feel safe, feel heard, feel understood, you're not shaming them, you're not blaming them, it really allows for, even at late stage in people's life, emotional stability, emotional growth. And it really showed me, and which was a big surprise to me, was just how intimate the last days of life were, or even the last weeks. But allowing that emotional safety allowed us to really be very clear and intimate with each other. And I mean that in an emotional way as much as a physical way, but it was a very profound and something I'd never really expected. And in many ways, I hope that we can continue to create that space now for patients and families and other people I connect to. It's interesting. It's something that I'm always mindful that we teach and we learn and we gain experience, and we're often in a very sort of, I would call, a narrow band. You know, we kind of understand, we know the facts, we know the figures, we know the protocols, And you can see this in the training doctors that, that's the way their examinations as to how they're achieving goals in their early career start. But then you start to see people moving back from that and unpacking and starting to show their own vulnerabilities towards patients and families and so forth and other staff. And I think that's when I really understand that people are connecting to the real emotion of a person facing a serious illness or having a sense of their life being threatened or consideration that maybe their problem is life limiting, is when a doctor, a nurse, allied health person kind of makes themselves vulnerable to that person so they feel safe to be vulnerable. The sad thing is that maybe a lot of people still, whatever part of healthcare they're working in, try to maintain a distance from being vulnerable. And I think patients really suffer because you get a pragmatic or a tick box response, or you get a response that's very process driven or an outcome of doing something. So instead of just connecting to the person, I think so for me, maturing in healthcare, people that can really be good healthcare professionals, I think if they can show their vulnerability, the other people pick up on it and you develop a much better therapeutic relationship. You become the therapist not by what you do or say, but just by being present and being vulnerable to the patients around you. And of course, that doesn't mean you're not still working in a very expert way around symptom management and whatever role, whether you're an oncologist or whether you're a surgeon, but patients really, really, I think, respect and can move along with you if you show that vulnerability. I think in many ways, you've sort of got to meet people halfway. I think understanding where the particular clinician is coming from and what is their stance and seeing if there is a potential for movement. And I think it often is demonstrated, which is what happens in a lot of healthcare settings, is by mentoring, demonstrating. It's no good giving them a book and say, read about vulnerability or emotional intelligence, so to speak. You need to really demonstrate it and to take people on, say, a ward round or come and meet their patient together in their rooms and just show how you can actually facilitate something that maybe they've had trouble with or difficulty with. I had a senior doctor the other day on a teleconference say, do you mind staying online afterwards? I just want to talk about some of the issues we're having in our team. And it really was one around that whole notion that their team was really struggling with these sort of distress and anger that patients and families were demonstrating. And very much it was around understanding that this whole notion of not quite seeing how you can approach things in a patient-centred way was a better way to work. And so we took that and then spent some time with a couple of cases actually face-to-face and together, just sort of demonstrating how we could reframe. And it's very simple. You just reframe it so it comes from a patient perspective, not necessarily the clinician's perspective, not the way they would default to when they're under a bit of emotional stress, which often, again, people are under stress. You know, they could be in a surgery or they could be dealing with a difficult communication around prognosis, but their own internal stresses tend to put up the barrier to sort of default to how they usually work rather than just letting the emotions come out a little bit. I can give an example. When I was recently seeing in our palliative care unit a doctor who was dying, and that often brings up a lot of stress, and we'd already had quite a bit of stress expressed by less senior members of our medical team because they're in a similar age, they've got children. So there's a lot of sort of that sense of their own distress at watching this. I think sometimes people can be a little bit sort of nervous about working around healthcare professionals because they can be ones accessing their own history. They might get their pathology results before you do. They might have other doctors in the family that are sort of giving them an idea of what they think is happening, and sometimes the care can be quite siloed. So I would often, in those situations, sit at the bedside. I mean, I do it for most patients, but I really make an effort to be at the bedside at their eye level. I sometimes will shake their hand or touch them, just know that there's a sort of presence there, it just depends. But really just to give a sense of, you know, what we would normally do, because sometimes if they are more anxious or stressed, or you've got a colleague who's there sort of advising them, I'd try and give a picture of what we would normally do and how we normally work, and see if we can be a bit congruent together and try and work that way. So it is all about the communication, and we can say, look, I want to see the world from your side, and I understand those anxieties. I can see that we're all going to be facing what you're going to be facing at some stage, and it must be difficult. So you go through those steps of acknowledging the emotion, trying to give a sense of empathetic understanding, which is true. It's not made up, and I'm not just sort of saying it for the sake of saying it. But then really getting, and often that really will bring people to the table. So that could be other doctors watching you. So that's when it's a good teaching moment for any doctor watching that scenario. And sometimes you can do that in somebody else's outpatient clinic. You can do it maybe with a GP in the community. You know, it is really just taking those moments to really feel like you can sort of push through and demonstrate it. I think that, to me, it's that sort of apprenticeship model. You know, I think we respond well to the see one and then do one sort of approach. It's interesting trying to understand why some doctors struggle with acknowledging the inevitability of dying is complex. We are a very heterogeneous group of medical practitioners, and I think that's reflected in those sorts of approaches. So the skill base to be, say, the most expert and most dedicated surgeon may be quite different in sort of personality shaping and construct than maybe the generalist who is there for the patient over many years and so forth, or the general practitioner. And I think we just have to acknowledge that, you know, we are quite heterogeneous. And I think for some, it is unfortunately that, you know, we're taught to put these sort of shells around ourselves to keep ourselves emotionally secure, and that's the way some people in their lives live. But because medical practitioners have in terms of hierarchy of influence, are often seen as being the ones a lot higher. They've got, you know, they do, their opinion matters, or it matters to the patients and their families in most jurisdictions. And I think sometimes that then, you know, they're sort of given this power without thinking much about it. And maybe they don't wield it in a way that's of benefit. But then there's a lot of other clinicians that do recognise that we can influence and we can affect and we can help people move along, and they're much more likely to approach people in that sort of patient-centred way. And it's something that you can switch on to. You know, sometimes we're dealing with our own life. You think now the sort of modelling of psychological well-being is all about trying to understand self so you can be more present for the world. It's interesting, in sort of modern social media, it seems to be creating a new shells, social media shells, that we present a very different face to the world. So maybe we should take learnings from that, as that this generation grows through that process and understands that being honest and truthful to yourself and the world is where you need to be. I always hope that doctors will find that place at some stage, but there are some where, you know, all of us have some sort of emotional damage, or there's issues that mean that shell that you've created is there for a reason, and breaking that shell can be very difficult for some people, particularly if they've had a traumatised upbringing, migration issues, refugee, war, all those sort of emotional, physical abuse type environments. And that doesn't mean doctors are immune from that. You know, often that's a driver for them to succeed. So we just need to recognise that as well. I guess we're all vulnerable to reaching for the next thing, the next best thing, and there's an expectation that somehow there's always going to be a solution to particular issues and problems. But I think we need to broaden the conversations before people run out of the options. And I think, you know, I guess on a superficial level you could say yes, people are trying to deny death and people are trying to prevent it and trying to get that next best thing. But I think really coming down to it, if you can bring into play consistent conversations with patients, good communication, you can sort of deepen the sort of prognostic understanding. And I think, again, patients may not want to hear that, but you can, I think it's increasingly being shown, and there's programs such as what's called the Serious Illness Conversations. You can deepen the prognostic understanding, but you can understand then their hopes and wishes and give context. Again, it comes back to that communication. So even though the next best thing is floating downstream, and somebody might get online and see that, you know, over in say the US, that this thing is being done, it doesn't necessarily mean it's available and it's achievable across health systems and so forth. While people want to push those barriers, I think we've got much more responsibility about, again, our healthcare professionals being much more consistent about that sort of those conversations. And then recognising when dying, there's a sort of inevitability to dying, and to communicate that. And yes, they might still stretch for the thing that's being done overseas or somewhere else in Australia, and that's fine, let them, if that's the way they see life. But then to still bring it back to what's really the sort of norm, I guess, of what we'd expect at this stage in this particular time. So at least families can see, or the patient can see, if the families are pushing them, they can see that whatever decision is being made from a position of understanding rather than just reactivity, I think. As an example, sometimes we often see this crossroad with the expectation that somehow when people's kidneys are failing, that renal dialysis is going to create a sort of saving procedural. But no one's really got any idea of just the time and energy and morbidity and difficulties that dialysis causes. And so yes, for younger people, dialysis is appropriate and achievable and can be obviously life-saving. But you get to a certain age, sort of teetering into your 70s, where it's a tipping point. And if you've got some other issues, because often people have a lot of vascular issues, they have problems with their kidneys, heart, all sorts of things, they spend more time in hospital than they do out for the rest of their life, because they're going into the dialysis chair 3 times a week, and then they get morbidity issues, so they have to go back into hospital. Their quality of life is impoverished. But what you do find is that you get families, you might get a patient deciding that's what they want for themselves, that they don't want to go on to dialysis, but then you'll get the crescendo of pressure coming from a family to move people into that space at all cost, irrespective of the quality of life issues. But that's where that decision making, and if it's a shared decision making that involves the family or others making that decision for the patient, that's fine, but as long as we understand. But really we've got a responsibility to kind of make sure that people are aware. They're creating something they don't really understand or recognise, and I think that's really important to keep those messages moving through, because you often then get people reflecting back, you know, saying, I would never have done this if I'd really understood or known what this meant. And then stopping becomes kind of impossible. This is the trickiness with all the new therapies with cancer care and cancer. There are amazing stories. I've seen them myself. I've seen people, we've put them into what we would call end-of-life phase. You know, they're in, death is inevitable, and they've been given their last dose of an immunotherapy. And you know why that's happened, because they're young, they've got young children, you know, there is a push. And in doing that, you know, people have turned around and they've lived another 9 months, a year afterwards. I'm just thinking of somebody while I'm talking about this, but it gave those children 9 more months with, so you can see why people want to push the boundaries. But at least for that family, I'm just thinking of the particular family, they knew that still we thought the inevitable was going to come. It just delayed it by about 9 months. But it is hard to know. It's hard to know. And sometimes I think, you know, depending on a life that is young is different to, say, somebody who's maybe in their 80s or early 90s, that I think people can understand what's at play and are much more likely to make sort of sound decisions, I think. That's our job, is to help, I said very much at the beginning, that navigate those decision making, the congruency side of the equation, you know. And that's the joy of palliative care. It's helping people understand what we see all the time and step into this space. It's not that we've got an agenda to make sure everyone dies. It's, you know, when we do see opportunity for treatment, we would be pushing and advocating for that treatment. You know, we want to take a very broad brushstroke palette. If we think this person needs, I was talking to somebody the other day, needs a second opinion, I said, look, it's all very well having the opinion of the one specialist you see, but you can go back and the multidisciplinary team in these cancer tumour stream meetings, they can re-examine that and see if there are other options, or if you're not happy, then we'll go to another cancer team and talk to them, you know. So sometimes it's just empowering people to get the information. If they come to the same conclusion, then at least they're informed, and then you can reflect back and you can steer the conversation towards maybe accepting death. I think increasingly people, I would say generally, watching our doctors coming into the training environment and then maturing, and then you see them as consultants, I think people are thinking a lot more about the broader brushstrokes of what it means to be in a sort of illness experience that's chronic and deteriorating and changing, and the effect of an intervention. And again, I guess I'm speaking in our healthcare system here in Australia, but I guess it's applicable to other healthcare systems. I think people do see and are evolving. I think where things can still sometimes go awry is in a more privatised systems. And even though in Australia it's changing, the private systems are coming under the umbrella of public scrutiny in terms of standards and quality. You know, so the standards, say in Australia, cover all hospitals now, whereas in the past there was sort of separation between public and private and so forth. And I think that's really important because it means we're all on a similar playing field. And look, there are always going to be clinicians who will sit outside, say, the bell-shaped curve of how clinicians operate. People really do want the best for their patients, but there'll always be the underperformers and the overperformers. And I think and what happens is, people will find those people if they're really determined to make sure they get that thing or that surgery. You know, they will find it. And I think there are going to be people that respond to that. You know, they become it's almost like their celebrity is they're the ones that take up the difficult cases and so forth. What I do understand though is that in terms of people per se, medical people working, I do think that we've always got an eye on the future. We understand where the situation is now, and I think for some people it's just their personality construct that means they're always going to be in that sort of more narrow band space. You know, it's just the way they operate in the world, and that's okay. You know, the tinkerer, the introvert who wants to kind of just be the surgeon, I think is, you know, it's not about the celebrity, it's not about the connection, it's about the doing. You know, maybe somebody else should be taking on that role with them. And that's more about the collaboration between team members, giving a clear picture and a message to a family, not just one individual sort of driving the sort of decision making and so forth. I think a good death means many things to many people, and it depends whose perspective you circle around, I guess. And for the same situation, it may be different for the staff that are at the bedside, for the patient who's going through the process, for the family, whoever. So it can be quite variable. For me, as I've already mentioned about people feeling safe and heard, for me it's the person who is going through the process, who is comfortable enough that they aren't distracted by difficult symptoms or difficult concerns, or are able to, you know, feel like they're in a safe psychological space, that they're not completely fear-driven. You know, there's a balance, obviously, but there's a sense that they can, again, they feel safe to be who they are, whatever that means to them. And I think that's great for the person, the patient. For me, the people that are surrounding the bedside, and that's the family, and it could be friends, it could be the staff, they need to be put their sort of emotional kind of interface to the background and be present to the person. And to me, that's a real sign of what I would see as leading to as good a death as possible, as death can be. It's going to be an emotional experience. It's, you know, and so you want those emotions to be there, but you want them to feel that indeed the person has died the way they wanted to die, if they're able to express that. Many examples of people where I always remember clearly, and I often take our junior doctors to come and see people where I think there's this really present family. And I can remember only a year and a half ago, a woman dying on our ward, and she had a very rough background and difficult upbringing, and there were emotional issues. But again, she felt safe where she was. And her sons, who had their own issues, they would come to us and say, I've got these own issues, said, look, we want our mum to have the best. Each of them had their own particular issues because they'd all had a pretty rough upbringing. But those guys were able to, and they were all in their mid-40s, early 50s, I think the oldest was maybe touching 60, but each of them was able to step back and say, look, I know I've got this problem at home. One's just separated from their wife. The other one, there was some issues to do with their children, but they were able to be present to their mum, and it was just a joy to see the way they interacted with each other, and they put their tensions behind them. The flip side of that, of course, is we often get families that are at crossbows with each other, and there's the person in the bed and there's the person kind of wanting a sense of comfort and safety, but the families are at loggerheads, and that's quite distressing for staff to see, because you know the discontinuity and the distress is long bubbling, or the anxiety about talking about death is, you know, don't talk about it, or don't acknowledge it, don't speak about it, can you call it something else, you know, so that plays out. And from my point of view, that's not such a good death. And I think if you look at any culture, any faith environment, really the truth still matters to everybody. That's what people want to feel. It's not a cultural thing, it's not a Western thing, it's not a this thing. I think everybody, when they're facing that, wants that sense. I think it's such a subjective. The person who's going through the process can't necessarily communicate to you unless, and so that's interesting. And again, the proximity to dying, we're sort of teaching generations not to necessarily be emotional and to sort of not go through the experience of emotions. And I think to judge a death by how emotional people feel around the death is difficult. You know, you might have a group saying this is the way you grieve, but the actual person wants to grieve in a different way. And so therefore the dissonance is about that, it's not about the death. So I think at the time of death, and even moving out from death, the reporting can be difficult. Having said that though, I still think there is value and there is evidence to suggest that you can still get relatively good evidence and data on some of the sort of questioning and discussions that can take place. From a pragmatic point of view, there are some things that could be achieved that are much more sort of outcome-based and produce data, which is important. So some of the things are maybe a goals of care form that's congruent to an advanced care plan or directive. When does that congruency happen? Does it come when people recognise the dying is occurring, or does it come in the last minute when suddenly they think, oh, we better get the goals of care sorted out? So if it's 4 or 5 days or a week before they die, you know, so you can get congruency and you can demonstrate that by the form. So it's a bit process driven. But there are those elements that you can actually see where dying is a bit more difficult in hospitals by the sort of process stuff that's in place prior to the death occurring. So there's a bit of a balance there. You need the quantitative, but you need the qualitative as well. And I think we're working towards being much more able to relate to both of those, but it takes a lot of design, it takes a lot of energy and effort to get those things into place in healthcare services and so forth. I think COVID was very instructive, and it was recognising that there was an opportunity. I think through government mechanisms as well as sort of organisational committees across Australia, that you could position yourself so you may have colleagues from other disciplines, surgical disciplines, oncology, at these tables. But again, you could present your opinion and your opinion was valued. And in fact, your opinion became quite important because the stress points for the community were, and for people in the community with COVID, was all about the connections of family, the communication of advice, which was being fractured because of COVID. So really we could come into our fore because we deal with these issues in our day-to-day work, and so it meant we could really put ourselves up forward as, in some ways, part of a team that could be experts on helping to shape communication and give mentoring and prompting to people that maybe don't necessarily have those skills or don't have as developed skills. The other area I think which was critically important is a lot of palliative care and end-of-life care really, I would say, is all about good care in the sense of the ethical navigation of care. You know, the blunt way of looking at it is saying you've got trying to bring congruency in the goals of care, congruency in the understanding of the person who's at the centre of the care. And I think it really gave us an opportunity in COVID to demonstrate how we can help navigate decision making so that the patient's empowered by the decision being made, as well as the clinician feeling that they've done their best and can see that it's not just a patient saying this is what they want, but it's actually genuinely agreed to in a sort of shared decision-making way. And I think for me that there was a big shift that we were able to use that as our expertise. And I continue to promote that in discussions. I promote that in meetings and committees now that COVID's starting to settle. So they're the two areas that I think we really had an opportunity to demonstrate how we could really be much more influential across healthcare. And when you're younger and people say to you, you know, you need to learn about leadership and you will be a leader at some stage, you think, oh God, you know, I'm just here doing my job type thing. And you read about leadership and it really doesn't, okay, tick, 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 do I do this, do I do that? It's a bit of it sits outside your lived experience, but I think what I've learned through palliative and end-of-life care, working with people that are dying, if you can hone your communication skills, you can be extremely of influence. Now that starts off maybe at the patient level, and that's how it started for me. I could see that patients were listening to me and I seemed to get them on board, and people would say to me, oh, your patients seem to take their medicines more regularly, and so you get to see it, but then you can see that other people see something in you, and over the years people have said things to me and suggested I join leadership programs or step away from just working in a small environment and think about the bigger picture, think about joining a committee that might change the way we put guidance down. So you can see it evolves, and you start to recognise there is something about the way you can work that builds a platform but also builds a way of working with people to try and communicate better so that you can make change and you can influence. And I think that's where leadership becomes quite profound and quite influential. And I often will reflect back to our junior doctors if they've communicated something particularly effectively with a family. And you can say, look, that was a really difficult situation, you did a great job. That's a real sense of leadership. You had the intern watching you, so you give those moments of celebrating these, because that helps them then to understand what leadership is about. Leadership isn't just about getting up and giving your opinion, just loudly saying it. It's really influencing the process of change for the better, and that's how I see it. Just kind of go with the flow a bit, but use the opportunities. I think part of leadership is understanding when the opportunities present themselves. And so for me, say COVID, I just thought that was one big opportunity to leverage the voice of palliative care, in that communication and ethics environment. When assisted dying came into play in Victoria, I just saw that as one big opportunity for palliative care to drive its message home, that it's all about the bigger picture, the bigger journey, the serious illness discussions. It's not just about getting a substance that for some people is going to be important for them to take. So I think I really feel that that's where leadership sits.